When an orthopedic surgeon opens a knee for replacement surgery, one of the first things they see, before the damaged cartilage, before the bone-on-bone grinding that brought the patient to the operating room, is the muscle surrounding the joint, specifically, how much of it is left. In patients over 65 who have been managing knee pain for years, that muscle is often dramatically reduced, not from disease, not from injury, from disuse, from a body that stopped asking those muscles to work hard, and those muscles that quietly obliged. What the patient almost never knows is this: the deterioration visible on that table did not begin with the arthritis. In many cases, the arthritis accelerated because the muscle was already gone. The joint lost its primary protection, the strong, active tissue that absorbs force before it reaches cartilage, and the grinding did the rest. The surgeon repairs what can be repaired, but no surgery replaces what was never maintained. That is what this video is about, not surgery, the opposite of surgery. Stairs are one of the most reliable indicators of functional strength in adults over 60. Not because climbing stairs is particularly difficult in isolation, but because it demands something that most common exercises do not: single leg strength, balance under load, and the precise muscular coordination to control a descent that is, mechanically speaking, harder on your joints than the climb up ever was. When stairs start to feel difficult, it is rarely because stairs have changed. It is because the specific muscles stairs depend on have weakened past the threshold where the movement feels safe. Think about what that threshold means when it keeps dropping. First, it is the long staircase, the one at the theater, the one at the grandchildren's house, that you start to dread quietly. Then it is your own stairs at home, the ones between your bedroom and your kitchen, that you begin to manage rather than simply use. Then it is the question you do not want to ask out loud: whether the layout of your life needs to change to accommodate what your body can no longer do. None of that is inevitable, but it is where unaddressed muscle loss goes, given enough time and no intervention. The title of this video promises the only 5 exercises you need. I want to be precise about what that means. There are hundreds of exercises that build general fitness. What there are not hundreds of is exercises that specifically train the joint angles, the muscle recruitment sequence, and the loading pattern that stair climbing demands. These 5 were chosen because each one targets a distinct piece of that mechanical puzzle. Miss any one of them, and the puzzle has a gap. Together, they address stair climbing completely, from the push off the bottom step to the controlled landing at the top, and equally importantly, the descent on the other side. Before we get into the exercises, I want to flag something about the 5th one. It is the exercise that orthopedic surgeons most wish their patients had been doing for the decade before they needed an appointment. The reason involves a specific muscle group that almost no one targets in a standard fitness routine, and whose absence surgeons observe repeatedly is the single most common mechanical precursor to the knee pain that eventually brings people through their door. I will name it and explain it fully at the end. For now, keep it in the back of your mind. Tell me in the comments, how confident do you feel on stairs right now? And where in the world are you watching from? I read every reply. Here are the 5 exercises. Exercise 1, sit to stand. The geometry of a stair step and the geometry of rising from a chair are almost identical. Your knee bends to roughly the same angle. Your weight shifts forward over the same point above your foot. Your quadriceps, the large muscles across the front of your thigh, fire through the same range of motion to produce the upward force. This is not a coincidence you can ignore. It means that every time you stand up from a chair without using your hands, you are performing a near-perfect rehearsal of the muscular demand that a staircase places on your body. Most people stand up from a chair the same way they have always done it, quickly, casually, with whatever combination of momentum and habit gets them upright. That approach leaves most of the training value on the table. The part of this movement that builds stair climbing strength is not the rising. It is the lowering, controlling your body back down to the seat slowly, taking 3 to 4 full seconds to descend, forces your quadriceps to work against gravity rather than simply surrendering to it. That controlled resistance is what builds the strength and the joint stability that stairs actually demand. Start with a firm chair at a standard height. Sit toward the front edge, feet flat on the floor, hip width apart. Rise without using your hands, then lower yourself back down slowly, counting to 4 before you reach the seat. If 4 seconds feels easy, go to 5 or 6. Aim for 10 repetitions. Rest for 60 seconds. Repeat twice more. As strength improves, try a lower surface. A coffee table height introduces a deeper knee bend and recruits the muscle through a fuller range. The progression is built into the furniture around you. One thing to be aware of, this exercise trains both legs simultaneously. Stairs do not. Each step up places your full body weight on a single leg for a fraction of a second. That is a different demand entirely, and it requires a different exercise. Exercise 2. Step-ups. A step-up trains exactly what sit-to-stand cannot. Find a staircase at home and use the bottom step, or use a sturdy box or low platform at roughly the same height. Lead with your weaker leg. Most people know which one that is without being told. Place that foot fully on the step, drive through the heel, and bring your body up until that leg is straight. Bring the trailing foot up to meet it. Then step back down, again leading with the weaker leg, controlling the descent rather than dropping. That lowering phase is where the single leg stability is actually built. Begin with 10 repetitions leading with the weaker leg, then switch. Keep your torso upright. The temptation to lean forward and use momentum is strong, and it is exactly what removes the training effect. If you need a hand on the wall for balance in the early weeks, use it. The goal is to reduce that support gradually as confidence builds. Step-ups train the lifting phase of each stair, but there is a second demand that most people never think about until their knees remind them, and it happens entirely on the way down. Exercise 3. Heel raises. Descending a staircase is mechanically harder than climbing one, not because it takes more effort, but because your muscles are working in an unfamiliar direction, lengthening under load rather than shortening to produce movement. The calf, specifically, plays 2 distinct roles in stair use. It drives the push-off at the back of each ascending step, and it acts as a braking system on the way down, decelerating your body weight with each landing. When the calf is weak, both of those functions degrade. The ascent loses its power, the descent loses its control, and the knee, which was never designed to absorb that load alone, begins to compensate in ways that produce the aching, grinding discomfort that most people attribute simply to age. Stand facing a wall or the back of a sturdy chair, fingertips resting lightly for balance, not gripping for support. Rise onto the balls of both feet as high as you can manage, hold for 1 second at the top, then lower slowly over 3 full seconds. That slow lowering is the braking system training. It is the part almost everyone skips, and it is the part that matters most for descent. Once both legs feel strong, progress to single leg heel raises. Stand on one foot, rise, hold, lower. 10 repetitions each side, 2 to 3 sets. The single leg version is a significant jump in demand. It is not unusual to feel the difference immediately. If the single leg version is not yet possible, continue with both feet and simply slow the lowering phase further. The calf manages force at the ankle, but the force coming down a staircase does not stay at the ankle, it travels upward. What happens next is entirely determined by what is waiting for it at the hip. Exercise 4, hip abduction. Orthopedic surgeons and the physical therapists who work alongside them observe a pattern so consistently that it has become almost predictable. In older adults with chronic knee pain, the quadriceps, the muscles at the front of the thigh, are usually the first thing everyone examines. Quad weakness is real, and the first 3 exercises in this video address it directly. But when surgeons look further up the chain at the hip, they find something that was often weakened long before the knee began complaining. A small muscle called the gluteus medius, tucked along the outer edge of your hip, that almost nobody thinks to train. The reason it matters on a staircase is mechanical. Every time you step up, your body is briefly balanced on a single leg. In that fraction of a second, your pelvis naturally wants to drop toward the side that is in the air, pulled down by the weight of the leg that hasn't landed yet. The gluteus medius is what prevents that drop. It fires laterally, holding the pelvis level, keeping your knee tracking straight over your foot, rather than caving inward under a tilted load. When that muscle is weak, the pelvis tilts on every step. The knee absorbs the misalignment. Over months and years, that misalignment is not trivial. It changes the angle at which the joint surfaces meet, accelerates cartilage wear, and produces the very deterioration that ends with a surgeon opening the joint to see what is left. This is what makes the gluteus medius different from the muscles trained in the first 3 exercises. Sit to stand and step-ups build the vertical force that drives you upward. Heel raises manage the front-to-back braking at the ankle. The gluteus medius operates on an entirely different axis. It works sideways, in the plane that keeps each step from pulling the knee out of alignment. The two demands do not substitute for each other. A leg that is strong vertically but unstable laterally will still place the knee under the kind of load that wears it down. The exercise that trains this most directly requires no equipment and can be done lying down, which makes it accessible even on days when the knees themselves are uncomfortable. Lie on your side on a firm surface. A yoga mat or carpet will do. Bottom leg slightly bent for stability, top leg straight. Without rotating your hip forward or backward, lift the top leg to about 45 degrees, hold for 2 seconds, then lower with control. The movement should feel like it comes from the outer hip, not the lower back. If you feel it in the back, you have likely allowed the pelvis to tilt. Reset and begin again. 15 repetitions each side, 2 sets. Once that feels manageable, add a resistance band just above the knees for the standing variation. Feet hip-width apart, slight bend in the knees, step sideways 10 paces in each direction. The standing version introduces the lateral stability work under load, closer to what the hip actually faces on a staircase. 4 exercises in. Each one owns a different piece of the problem. Sit to stand builds the foundational strength both legs need. Step-ups train each leg to carry the full load alone. Heel raises put the braking system back into the calf for descent. And the hip work keeps the knee tracking straight on every single step. What remains is the 5th, and this one, more than any other, is the exercise that surgeons wish they could prescribe before the damage is done rather than after. Exercise 5, terminal knee extension. At the very beginning of this video, I described what a surgeon sees when they open a knee that has been degenerating for years. Reduced muscle, not from disease, from disuse. I told you that in many cases the arthritis did not cause the muscle loss. The muscle loss came first, leaving the joint without its primary protection until the grinding did the damage. I want to name that muscle now because it is specific, it is trainable, and it is almost certainly one you have never deliberately worked in your life. It is called the vastus medialis. You can find it yourself right now. Place your hand on the inside of your knee and straighten your leg fully. The firm, teardrop-shaped contraction you feel in the last few degrees of that movement is it. Small, precise. And in most adults over 60 who experience knee pain on stairs, it is substantially weaker than the surrounding muscle, sometimes barely functioning at all. Every other quadriceps muscle pulls the kneecap upward and slightly outward as the knee straightens. The vastus medialis pulls it inward, balancing that force and keeping the kneecap centered in the groove it is designed to travel through. When it weakens, the kneecap begins to track toward the outside of the groove on every single movement. On flat ground, this creates a dull ache. On stairs, where the knee is bending and straightening under full body weight with each step, it creates the grinding, aching, sometimes sharp discomfort that most people assume is simply the inevitable cost of aging. It is not inevitable. It is mechanical, and it responds to the right exercise. Researchers studying adults between 60 and 75 with chronic knee pain found that a targeted 8-week program emphasizing the final 15 degrees of knee extension, the exact range where the vastus medialis does its work, produced a significant reduction in stair-related pain and a measurable improvement in stair climbing confidence scores, even in participants who had been managing symptoms for several years. The exercise that drove those results requires a resistance band and about 4 minutes. Loop a resistance band around a fixed object at knee height. A stair post, a heavy piece of furniture, or a door anchor works well. Step back until the band is taut behind the knee, your knee in a slight bend. From there, straighten your leg fully, squeeze hard in that last inch, and hold for 2 seconds before releasing. That is 1 repetition. You are not doing a full leg extension. You are working only the final range, the part that wakes this muscle up. 15 repetitions each leg, 2 to 3 sets. Most people feel a contraction at the inner knee they have never consciously felt before. That is exactly what you are looking for. If a resistance band is not available, a rolled towel placed under the knee while seated works as a starting point. Sit in a chair, place the towel roll under your knee so it is slightly elevated, then press the back of the knee gently downward into the towel and hold for 5 seconds. Less resistance than the band, but it activates the same terminal range and begins to wake the muscle up. Do this exercise last in your routine after the others have already warmed the joint and the surrounding tissue. Within 2 to 3 weeks, most people feel a change in how the knee behaves on stairs. Not dramatic, not instant, but a quieting of the discomfort that had become background noise. That staircase that has been asking more of you than it used to, the one you take more carefully now, the one where you find yourself reaching for the railing without thinking, is the same staircase you will be climbing differently in 8 weeks. Not because anything was fixed, because the muscles that were always supposed to be doing this work will finally be doing it again. The full exercise guide, sets, repetitions, progressions, and the order to do them in, is written out in the description below this video. Save it, come back to it, leave a comment and tell me which of these 5 you are starting with. And if someone in your life has been struggling with stairs and quietly accepting it as the new normal, share this video with them. What feels permanent often is not. Sometimes it is just a muscle waiting to be asked. Take good care of yourself. I will see you in the next one.